Well, good morning, everyone. Thank you all so much for being here, and I wanted to say thank you to Michael for the invitation to be able to be here today. Thank you. And also for the promotion. That was way easier than going through P&T committee, so thanks. I'm an associate professor, and I'm the department chair of Health Systems and Implementation Science at the Virginia Tech Curlian School of Medicine. Just before I get started, I wanted to kind of give us a couple of disclaimers. So first, I am a PhD researcher. That is my perspective. I come from the world of human factors, so that will be the space that I will be trying to talk about today. Also, as you will see very soon, I did not use AI to develop this presentation. So there may be some fun spelling errors and things like that. But just the same, given this rather large task of talking a little bit about human factors and the history of human factors engineering as well as systems engineering, I tried to kind of take a tack of hitting the history lightly and then really trying to dive into what is the implication of this history for the topic at hand today. So with that, here we go. So I thought first I would start maybe with a story. So this is my dad. My dad is a pastor. He was the chaplain of Roanoke College for 30 years, and he is hands down the world's worst person at retirement. He has no fewer than 3 jobs at all times since he retired 12 years ago. And this is him on his favorite Wednesday and Saturday activity, which is building houses with Habitat for Humanity. So you will find him on a job site across Roanoke or the New River Valley every Wednesday and Saturday mornings. So he is an active person, has an active mind, and is constantly on the move. Back when I was a teenager, I came home from school one day and walked down the hill and down into our driveway to see my dad and my mom walking quickly toward the car, my mom helping my dad as they were moving toward the car. And they told me I needed to look after my brother because they had to go to the ER. And I didn't really understand what was happening. I knew my dad looked pale. He didn't look like his normal active self. He was kind of hunched over a little bit, and his body wasn't moving. So he went to the hospital. He was admitted for kind of an confusing or kind of undiagnosis, I guess. I don't know what one would call that. But he was observed for a number of days, and as the days went on and on, he got sicker and sicker and sicker, and it was not clear what was going on. His body continued to seize up, and he just continued to deteriorate fairly quickly. He was in the hospital for what my teenage mind remembers as about 2 weeks. I don't know if that's accurate or not, but the diagnosis remained elusive. Finally, after a fairly long time, a team of internal medicine docs and hem-onc identified that he had had a tick bite a number of weeks earlier, and it had just manifested in Lyme's disease. And then he got an infection simultaneously and got a second infection, whether that was iatrogenic, I don't know, but he got a second infection, and finally the resulting diagnosis was hemolytic anemia. Once the diagnosis was identified, we were on the up and up. They were able to treat him, and obviously he's just fine now. See? At the time, I remember thinking to myself, I thought medicine was like science. I thought this was very clear. I thought we kind of did our tests and we used deductive reasoning and we identified why people are sick, and then we move on with our lives. It was one of my first experiences realizing this is actually a bit of art mixed in with the science. For me, this was kind of a moment where I decided, hey, I wonder how I get to learn more about this particular field. How do I get to better understand how people, these incredible, frontline carers, make these decisions and do this work on a day-to-day basis? So, as I mentioned, my dad is a pastor and was a minister at a college for many years. So when it was time for me to go to college, he said, you can go to any college that you want on this list of schools with which we get tuition exchange. And so I went to a small liberal arts school in Ohio, and while I was there, I got the good fortune to work at Wright-Patterson Air Force Base. This was my first exposure to human factors and to better understanding how we could use automation and things like that to better understand human performance. So my job was as a researcher analyzing pupillography data, looking at pilots we decked them out in all these physiological sensors, and we looked at how could we provide adaptive aiding based on their physiology. So this is my first intro to workload. This is my first intro to adaptive automation, and my first introduction to measuring multimodal physiology in near real time. As we started to do this work, I got really excited about it, and I went to work with Raja Parasuraman, who was one of the leaders of a field called neuroergonomics, which is kind of taking the brain and trying to understand how human performance works, utilizing brain waves specifically, and then additional kind of neuro measures. After working with Raja, I got the opportunity to go to Mayo Clinic, which was the first real exposure to what does it mean to do human factors in the healthcare setting. What does it mean to watch these extraordinary clinicians in the operating room or in the inpatient setting or in the outpatient setting actually do their work? And the great thing about Mayo Clinic was you could not be myopic. You could not be a mile deep and an inch wide like most PhDs would prefer to be. You had to be able to see and understand lots of different things simultaneously. And this is where I really got excited about human factors. Now, I say this all not because I wanted to do a talk about myself, but you're welcome. No, I'm kidding. I say this because I wanted to drive home the fact that this is a really multimodal, multidisciplinary kind of space to come into as a human factors person. So just to provide us all with kind of a core definition so that we can utilize it, I don't know, for the rest of the meeting, I won't be so presumptive, but at least for the rest of this talk. So human factors is an applied field of study that examines human abilities, limitations, and behaviors to inform the design of work. And within work, I mean products, processes, and systems. This is the academic definition, so I'll just drive home a couple of specifics within this definition. First, applied. So we are constantly thinking about how do we actually make this work in the work setting. The second is human. So fundamentally, we are thinking about how do humans move through the world. Humans are intellectual, cognitive creatures. They are social creatures. So both of those aspects go into how you think about human factors. And then third is the design of work. So we're focusing on people at work, not necessarily people in the context of their daily lives, although those things do influence how you interact at work. If I put it really simply, and this is how I would introduce it to my grandma or to friends and family. For a while, my mother-in-law said I was a nuclear psychologist, which, sure. The way that I would introduce it is humans are fallible and humans are brilliant. It's both and. In human factors, we seek to minimize the impact of that fallibility and we seek to maximize the brilliance. I have been told before that we human factors people seem kind of negative. Because we often talk by default about how bad humans are at stuff. And it's true, we are bad at stuff. But I promise, it's not negativity, it's not cynicism. It's actually exploring the fact that humans are human and they work within a context. Humans are brilliant, but we have the responsibility to design systems to maximize that brilliance and we need to account for that influence of the context. So what this means is that we acknowledge that there's more going on in mistakes and errors than just one individual making a bad move at a given point in time, that there's tons of other stuff that are influencing how things work on a day-to-day basis. In an error, it's not just a matter of a negligent human, it's a human functioning within their own fallibility and their own brilliance within the limitations and barriers and facilitators of a complex adaptive system. So, in healthcare, unlike other high risk or high safety industries like aviation or nuclear power, the risk is not at a mass scale. The risk is one individual person at a time. And the uncertainty and the number of variables that are required for input are incredibly high. So I don't know with this story with my dad, I don't know that that was necessarily a medical error. I don't want to make the case that it was. I think it was a really complex and confusing diagnosis that was presenting in a way that was not clear. But as he got sicker and sicker and was really not looking good, that's how long it took for things to kind of, for us to figure out what was going on. So to me, the question is not, why did the doctors miss this diagnosis for so long, and why did they not realize what was going on? But rather, what the inimitable Bob Weir said, people generally come to work to do the right thing. If they can't or don't, it's our job to figure out why. And that, to me, is kind of at the core of human factors. So unfortunately, this typically manifests as us looking over our shoulders at a serious safety event or something like that, when it seems like, with that 20/20 hindsight, everything should have been clear. This was an easy diagnosis. We just missed X, Y, and Z. I would argue that this is where we get that human fallibility and human brilliance. So there are many reasons why humans perform the way that they do. You've got that individual cognition. So we all have these things that we are susceptible to, no matter who you are, simply because you're human. We are susceptible to making mistakes when there are interruptions, particularly when you are doing a task that requires short-term memory. We are susceptible to bias, both cognitive bias and social bias. We are cognitive misers, so we want to make the simplest thing work fast. We don't want to look for zebras. Or sometimes we're not cognitive misers and we only see zebras. Humans are weird. We are susceptible to things like workload. We are susceptible to things like fatigue. All of these things are what the human is bringing to the table. Now that human functions within a context of lots of different kinds of technology. So we all have stuff that we're using to do our job. And the design, how much we trust it, the transparency of the work that we're doing, all influences how we interact with that particular piece of technology. The usability, the ease of use, the presence or absence, familiarity, all of those things influence. There's also social aspects that influence how people interact with the context around them. Things like social trust, things like hierarchy, particularly in healthcare. This is a really important social influencer. Things like familiarity with the team, leadership, and so on and so on and so on. There's lots of social influences that change how you might interact in a given situation, whether or not people speak up, those kinds of things. And then there's the overarching macro system in which we all sit and function. Things like culture or values or whatever, all of this stuff influences how you interact within your work. So if we end up in a situation where we are blaming human error alone, we have entirely missed the point. In the context of the reality of the world in which we live, the choices, and in my dad's case, delay or confusion while he was actively deteriorating, those choices made sense. People were doing their best. They were being their brilliant best. But it's the job of a human factors engineer to understand that human fallibility and the brilliance within any sort of given system. Our job isn't necessarily to delete errors or to never make another error occur. That is futile. And I want to emphasize that because often we're told zero mistakes, zero mistakes, zero harm is what I would argue. Our job isn't to understand the error or to make humans stop erring. That is futile work. Our job is to identify the constellation of causes and remove the consequences if we can, or at least mitigate the consequences of an error as much as possible. Humans are going to err, so we got to make the consequences as minimal as possible. And human error may sit as the cause, as the consequence, not necessarily the cause. So in terms of where does human factors come from, this is the history section of the talk. Human factors, see error. Human factors was born out of a combination between psychology, engineering, and design, and a couple of other fields, but the Venn diagram got pretty complicated, so I just kind of narrowed myself. See, I did not use AI to make this presentation. Human factors sits at that intersection between all of these different disciplines. So some of your human factors colleagues may come from an engineering perspective. They may have that really solid background in industrial and systems engineering or mechanical engineering, or like me, they may come from the psychology side. How do people think, the cognition side, learning, all of those kinds of things. Or even the industrial organizational side, so teams, leadership, et cetera. And then there's another set of folks who come from design, so industrial design or other areas, even architecture. Just a super brief history. Human factors is a fairly young science. It was born after World War II, when there were pilots making fundamental errors within aircraft. For example, opening the belly of the plane rather than raising the flaps. And what happened was, these are expensive planes and these are expensive errors, and we've just trained pilots really a lot. And so we don't want these errors to keep on happening. So when these errors started to occur, whoever the powers that be are within the military said, wait a second, we maybe need some psychology up in here because people are making mistakes that they shouldn't make. And so they pulled in psychologists who started to look at the design of things like the cockpit and the layout of certain buttons and certain levers. As it turns out, the lever that can open the belly of the plane might be right next to the lever that puts the flaps up. Those seem like they should be distinct. And so, those kinds of design things are where human factors really first started. The transportation sector has been kind of the leader in human factors in the field overall, particularly in aviation. Because there was an investment by the military in saying, we need our humans to perform at their maximal capacity. And so how do we, again, augment that brilliance and minimize that fallibility, which is predictable, according to what we know about psychology? So in the years after World War II, much of the exploration within human factors were things that happen in the head. So things like better understanding of how attention is deployed. How is visuospatial attention deployed? Do you do it like a lightning, or like a lighthouse? Do you do it like a whole kind of room's worth? Things like situation awareness. How do you understand what happened, what happened previously, what is happening, what's going to happen? How do people intake different kinds of stimuli, auditory versus visual, simultaneous stimuli, et cetera? How do you deploy your attention? And then a lot of work around workload. How do we maintain workload? What happens when we are in low workload versus high workload? And how all of this ultimately influences the human doing the work. The researchers specifically during this time became really preoccupied with the interactions of humans and technology. And at that time, that largely meant hardware. Some software, but largely meant hardware. So how are people doing stuff with stuff? This translated into healthcare, thankfully, with the publication of To Err Is Human. That really was the kickoff in kind of 99, 2000 of not only federal funding, but of acknowledging that actually within the field of healthcare, maybe we should think about human performance in a different way. Maybe we shouldn't just depend on our doctors to be heroic at all times. Maybe we should acknowledge that potentially 48-hour shifts might not be the world's best idea that we've ever had. Maybe we should think about how many things nurses are asked to keep in their short-term memory at any given point in time. So with the publication of To Err Is Human from the National Academies came funding for things like ARC and an increase in standards at the FDA, things requiring human factors testing for new devices and things like that. And we started to find those giants that we all actually stand on the shoulders of now. People like Charles Vincent in the UK, James Reason, also in the UK, Lucian Leape, who was a surgeon who really got excited about this in the US, and through the Lucian Leape Institute, as well as some really seminal publications, started to define what does error look like? How many are they? Folks like Richard Cook, Eric Holnagel, Chris Wickens, Dave Woods, they started talking about resilience engineering. What does that mean? What is safety one? What is safety two? These folks were setting the stage decades ago. Then we start to translate into healthcare. So Bob Weers, an emergency medicine physician, started to really think about what does this look like within the field. People like Pascal Carrion, who bring in the macro ergonomic approach. And then that's kind of your first generation. Then we start to have a second generation of researchers who are starting to dive deeper into healthcare. Folks like Doug Wigman, Benzie Karsh, Shauna Perry, and then a couple of people who are actually here today, or will be later, Terry Fairbanks, Ken Ketchpole, Emily Patterson, Mary Patterson, all of the Pattersons, really just crushing generally. They're not related, but I still believe. Folks like Rona Flynn, Francesca Chan, these guys started to say, hey, look, let's make this work within the field, within healthcare. Let's start to manage that complexity. Let's start to talk about how do we actually translate this into the daily work of healthcare, not just do the research. And all of these folks have spawned tons of grad students, have spawned tons of applied folks. I just came from HFES in healthcare a couple weeks ago, and there were thousands of young human factor scientists there. They want to be working in healthcare. This is a tremendous opportunity space for our field. Also, there have been more integration of folks who may not necessarily call it human factors in healthcare, but are using similar principles. Folks like Atul Gawande, Peter Pronovost, others who are doing tremendous work translating our understanding of what human capabilities and limitations are into day-to-day practice. There we go. So we have really begun to acknowledge, begun to acknowledge that work remains incredibly complex. And so we've got to really think about how does that human interact with the technology in a way that is useful, that is sustainable. In the past, human factors really focused on the head, so optimizing technology as a tool for daily work. So something that we all do, just to kind of translate. Driving is something that all of us do on a semi-daily basis. When you are doing a driving task, you are a human with all of kind of your human stuff going on inside your head, but you're interacting with complex technology, and there is really high consequence when things go wrong. Automation started to creep into driving, right? Through cruise control or through lane indicators, and now we have fully autonomous vehicles. What has happened with that is that we have shifted the work away from the work of in the head work. We have shifted it away from attention deployment necessarily. Now that's taken over by somebody else or by automation. Now what we have to do is transition our role as humans into a role of oversight as opposed to a role of doing. And that is a significant difference in the world of human factors. In the UK, this particular kind of transition would be called cognitive complacency. And that sounds like it's bad, it's not. It just means that your brain is doing something else. You're in low workload. Error may not happen necessarily in low workload, so to speak. What happens is when you have to shift really quickly from low workload to high workload, that's where errors can happen. And so when we are talking about automation or AI or other kinds of things coming into the healthcare setting, I think we need to really think hard about what is this shift that we're asking humans to do, and what does that mean in terms of the rapid shift from I'm engaging in an oversight task to I am now required immediately to have a depth of understanding in which I can intervene. In human factors overall, that means that what we have done is taken or kind of shifted our approach away from just the individual cognitive approach and the hardware approach to thinking much more about systems. So systems and their design influence human performance, because as human and automation become more intertwined, we have to think further about how we are integrating humans into this complex adaptive system. Humans, rather than kind of the previous mental model of humans being kind of the runner of the system, we are now part of the system. We are one element within the system. And so how do we get the best out of that particular system? So it kind of moves away from exclusively humans are brilliant, humans are fallible, to system can potentially be brilliant, system is fallible. So when I was thinking about this particular talk, it really occurred to me that human factors was born because technology started to outstrip human capabilities and limitations. That's where the field came from. And guess where we are right now? We are at a point where technology is beginning to outstrip our human capabilities and limitations. We have increasing automation. We have increasing autonomous automation and interdependent work. We also have a change in what we are looking for from the human themselves. It's less about the human having control and much more about our job being monitoring and overseeing the system. And so what I would argue is this is a moment where I think we need to think a little bit about how human factors should be transitioning. What's our inflection point as a field as we think about how this can look in the future? So there's a few issues that I think specifically when we were talking about pushing toward more autonomous technology, AI, and the like, that we can think about. Trust now will become ever more important. How do you know when to trust your automation? What does trustworthy automation look like? How do you know when it's not sure? The other element to trust is how do you override? We already know human to human overriding when it comes to safety is difficult. Right? That medical student who notices you're about to open the wrong whatever, that's hard to speak up. What if your automation is telling you something and you're like, I don't think that's right? How do you engage in that override? And also with automation, especially if it's not transparent, maybe it knows more than you do. Maybe it's identified more than you were able to. So how do you know, and how are you able to do that? Again, I talked a little bit about this, but this idea of locus of control. We are moving from the humans having control into the system having control, and that is a substantial change. And that means we have to think differently about the work that humans do. Our old methods, I don't think, are going to necessarily continue to work in the way that they have in the past. Situation awareness now is a whole new thing, right? Because what we understood to be happening in the past and in the future is different if you've got an AI tool engaged. Also, we're shifting workload. I talked a little bit about this already, but we are shifting the way that we are asking the humans to do their work. Now, these might still sound like in the head cognitive issues, but the change is we've got a teammate now that is like literally kind of inside our heads, but also inside the system. So it's different. It's no longer a singular or even a human team task. This is a technology task. So I wanted to talk a bit about where I know in this meeting, just from looking at the agenda, we're going to be future projecting. And we're going to be thinking really hard about how do we deliberately integrate this. I wanted to show you what this looks like today for me in my day-to-day life working at a healthcare system. So this is, I apologize for how little it is. It'll be okay, I promise. You all have human limitations, it's fine. This is, I had to take my mom for a colonoscopy, totally routine, not a big deal. She just needed somebody to drive her home, so I went with her. So as we are arriving at the hospital, I started to pay attention to all of the different interactions that we were having, all the different steps that were occurring as we were going through this particular process. So there were a number of moments where we arrived, there were a significant number of waiting moments, and then I started to track how frequently we interacted with a computer. So I went back and I coded it because I'm a dork. So in the gray, these are physical walking. That's physical movement that we did throughout the building. In the kind of orangey color, those were interactions with either other people or interactions that we had to exchange some sort of information, but it was people to people. The yellows are name, birth date, and procedure, so the number of times she repeated name, birth date, and procedure. The blues are computer. And I said computer, not AI, because this was transactional computer interaction. The reds are weight. And the green is when we talked to a human and kind of how they were. So the bright greens are when we talked to the anesthesiologist and the doc who was going to do her procedure, and they were both absolutely exhausted human beings. So when we're mentioning things like burnout, these were your cases. Like, they were the poster children if they could have summoned the energy to have a picture. These were those people. So as we went through this whole process, I started to think about, where are there opportunities for technology to really be helpful in this particular process? And we're not there yet, at least in particular in our hospital system. The frontline use of healthcare technology was really tech as a document hub. It was just a holder of information. It wasn't necessarily this awesome, new, powerful thing that could augment work. And so again, as you all are thinking and using your brilliance today to come up with what this should look like next, I would encourage you to really think about, what are those friction moments that deserve that AI integration? I am still, in my mind, the jury is out. We spent a ton of time trying to develop AI specifically around clinical decision support. And I'm very curious if there's additional opportunity space to actually develop it more around some of these administrative things. That's not my idea, obviously. Other people have had that idea before. But to me, those are the friction points where it could actually make a difference for a frontline clinician or for a patient in the moment, not necessarily exclusively in clinical decision support. So the question then becomes, from a human factors perspective, how do we work in partnership? What do we do when automation has most of the control, but the human is engaged in an overseeing task? This is incredibly difficult from a human factors perspective, because we are shifting what we are asking of the human. We are no longer the doers, we are now the overseers. So now we've got to understand those human skills, which actually we're pretty bad at, of things like vigilance. Because all of a sudden, think about it, if you're going along and you're in cruise control and then you have to make a rapid decision, remember, that's where the errors occur, and that's kind of a synonymous thing that's going to start to happen. We're going to have to engage as curators of information. And that's a really tricky thing when you're not coming in with expertise already. We engage in a different skill set around editing and rapid shifts from complacency to engaged workload. We also will have to figure out, how are we going to share and update our shared situation awareness without being the frontline doers? All of these have consequences for the individual and for their own cognitive work, but they also have simultaneous and substantial consequences for the system. Remember, the humans are now part of the system, not overseeing the system. So these middle steps between kind of what we're doing now, which is Document Hub, and AI assisted, those middle steps for human performance are not only incredibly necessary, but they are very tricky from a human performance perspective. We've got a logarithmic increase in technology and technology availability and capacity. But most of healthcare, much of healthcare, remains analog. And so what does that mean as we are integrating the technology? And again, what does that mean? Not just from a cognitive standpoint, but from a workload standpoint, from a culture standpoint, et cetera. Most human factors people would say, please just include me at the early stages of design. Please. I would argue that things are moving so fast that I don't even know when the early stage of design is. Like, it was like 4 years ago or yesterday or 2 minutes ago, I don't know, but it's over now. So the design phase, I think, is continually iterating and continually happening. And not only that, is it's diffuse, it's nimble. These are happening in startups. This is happening and changing at a level that there is limited control over organizationally. Also, there's a lot of integration of things based on, I put charismatic here, but based on exciting ideas. I was at a wonderful conference, a digital health conference, actually at Stanford last year. And one of the EM docs was talking right next to someone who had developed this amazing, very, very authoritative sepsis predictor app. And the EM doc said, that's awesome. How do you integrate it? And the sepsis guy was like, well, you just stick it into the medical record. And the doc's like, okay. And then I'm not trying to make fun of that person. It's just we are in two different worlds, and the tech world is exploding at a pace that's really hard for healthcare to keep up with. Also, as we all know and are currently experiencing, our regulatory world right now is shifting rapidly and daily. And so that means not only is funding for this kind of work changing and shifting, but how it's going to be regulated is changing and shifting. I really appreciated this quote from a recent article in Information Systems Science. I'll read it for the folks in the back. Surprisingly little effort is spent on understanding the cognitive challenges of decision augmentation with AI-based systems, although these systems make it more difficult for decision makers to evaluate the correctness of system advice and decide whether to accept or reject it. And I think that's kind of core when we are thinking about how we are designing these systems. So I'm kind of at my conclusion moment here, and what I wanted to really emphasize is these are different aspects of the system and of the human themselves that influence how you do your work and influence how the system overall itself interacts and the context in which humans work, how we can actually do our job. I think we have a design moment here for you all to be thinking really hard about the design of AI and implementation for human use, with the human as part of the system. This is a picture of stars being born, because I think that's we're kind of talking about complexity, maybe not at that level, but maybe close. So I have a couple of open questions that I thought I would put out to this group of people. So for engineers, for policymakers, regulators, human factors people, clinicians, these are things that I have been thinking about that I would love advice on. How can we better design for safety when we have an inadequate understanding of human performance in this new context? How do we design for safety when we don't get yet how we're going to do it wrong? What does this mean in terms of a human's context within the system? And what does this mean as automation or tech or AI is changing rapidly? The other question I think is really interesting is, do our old human factors methods work? Is task analysis still good enough? We've got to really be thinking about what are our additional methods that we can pull out of our hats. Obviously, it's a mixture of qualitative and quantitative, but how are we going to engage in this particular kind of an analysis? I think usability is very important, but I think it's kind of, you're kind of at the last stage by the time you're using usability methodologies. And then finally, how do we better prepare all of our students and all of the learners across domains for practice in partnership with tech, not with tech as a tool? So this is how I feel, honestly. We are moving at a pace that is so incredibly rapid right now that we have got to figure out kind of how we're going to work together and how we're going to interact with AI and technology. Again, I know human factors people get the reputation of being negative. I'm not negative about this. I genuinely just think we need to figure out how we're going to get after it, because it's really exciting and could make a monstrous difference for patients, for providers, and for the daily work of healthcare that's so hard. So I sincerely appreciate your time and the opportunity to speak with you today. I am very encouraged by the number of people in this room and the high caliber of folks that are here. So thank you so much. I really appreciate it.